In this second part, we will discuss another area for interventions by healthcare professionals that could greatly improve the lives of our patients with COPD and asthma: adherence. With appropriate therapy, most asthma can be controlled. Those with asthma should be able to live normal lives. Most hospitalizations are preventable with the right controller medicines and successful implementation of a comprehensive and effective asthma plan. COPD is less responsive to therapy, but adherence is still very important. The mortality rate in those non-adherent to therapy has been reported to be about 20%. In those adherent to therapy, the mortality rate is approximately half that, or about 11%. Annual hospitalization rates are also much higher in those who are non-adherent, about 27% versus 15% in those who are adherent. As healthcare professionals, we can work together with patients to encourage adherence and improve patient outcomes. In the second part on adherence, we will define adherence terms. Differences will be explained and examples of each will be provided. Differentiate between common adherence myths and the actual reasons that patients provide for non-adherence to daily respiratory medicines. Discuss provider behaviors, interventions, and messages to patients that would likely improve patient adherence. Let's start with defining two common terms which are sometimes used interchangeably but actually have different meanings. Compliance is the degree to which a patient's behavior is consistent with the prescriber's recommendations. This term has fallen into disfavor with the recognition of the importance of patients' participation in making decisions regarding their own health. Adherence has become the generally preferred term in the United States. Adherence is the degree to which a patient's behavior meets the agreed-upon plan with the prescriber. There are differing cut points used to assess whether a patient is adherent to a medication. A common cut point for adherence is taking at least 80% of the prescribed doses within the period being evaluated. Another related term is persistence. Persistence is whether the patient continues a medication in some fashion beyond the first month of treatment. However, as we will talk about shortly, a patient may persist in taking a medicine but not actually meet the definition of adherent. For non-adherence, there are three different terms describing different types of non-adherence. Primary non-adherence is when the patient never begins the medicine. Many paper prescriptions are never brought to the pharmacy. With electronic prescribing, more prescriptions actually reach the pharmacy, but some of those are never picked up by the patient. It is also possible that a patient picks up a prescription but never initiates the medicine. The exact incidence is unknown, but primary non-adherence is likely a significant issue. Secondary non-adherence is when a patient begins taking a medication but subsequently stops it. Secondary non-adherence can also be called non-persistence. Some project that incidence of secondary non-adherence may be as high as 50% for chronic medicines after the first year of therapy. Improper use may be the most common type of non-adherence. With improper use, the patient continues to take the medication in some fashion. Improper use includes a variety of behaviors. For example, the patient takes a different dose or at a different frequency. They may use the medicine intermittently, only when they think they need it. It is important to recognize that improper use could involve either over or under use of the medicine. So, improper use could technically still be classified as persistence. But, as the manner of use is inconsistent with the prescriber instructions, improper use is also considered non-adherent. Improper use is also extremely common. To measure adherence, drug benefit managers may review prescription claims data to calculate the percentage of days covered by the medicine, or PDC. The PDC calculates the percentage of days that patients have access to medicine during the period under consideration. For example, during the first 2 refills, the patient picked up the refill prescription 2 weeks late each time. So, for the 3-month period, the patient had access to the medicine during 60 of the 90 days under consideration. This would be a PDC of 60 over 90, or 67%. A goal PDC of 80 to 100% is often used to define good adherence. But it is important to realize that the PDC only measures access to medicine. The PDC does not show how patients are actually taking the medicine. The patient may have stopped the medicine since picking up the last refill, non-persistence, or maybe taking it differently than the prescribed instructions, improper use. So, a PDC of more than 80% is a useful screen for non-adherence. However, a PDC of more than 80% does not necessarily mean that the patient is still persisting in taking the medicine or following the instructions when taking the medicine. All of these non-adherence patterns, primary and secondary non-adherence, improper use, are common in those with asthma and COPD. Exact figures are not known. In one study, 54% of patients with COPD stopped their medicines periodically. Adherence to anticholinergic and corticosteroid medicines was only about 40%. For asthma, some reports of non-adherence with controller medicines are as high as 70%. In patients with either asthma and COPD, overuse of short-acting beta agonists and controller medicines, especially during exacerbations, is common. There are some common myths regarding non-adherence. One myth is that adherence is predictable. Healthcare providers may think they can tell which of their patients are adherent and non-adherent. They may think that their patients would tell them if they stopped medicines or they are taking them differently. In reality, patients often perceive taking their medicines differently than providers. They see their behavior as modifying instructions to fit their daily lives or changing circumstances. So they don't perceive adjusting medication instructions as being non-adherent. A variation of this first myth is that it is mostly poor or uneducated patients who are non-adherent to medications. Non-adherence crosses all economic and educational levels. Another adherence myth is that adherence to medicines is all or none. That is, patients are either taking all prescribed medicines as prescribed or none of them. In reality, patients may take medicines for some conditions and not others. For example, a patient with COPD may take tiotropium, but not their inhaled corticosteroid. Another major adherence myth is that most non-adherence is unintentional. That is, most non-adherence is due to forgetting to take the medicine, misunderstanding instructions, or because patients cannot afford their medicines. Forgetfulness, confusion, and cost of medicine can be barriers to adherence. If forgetfulness is the problem, reminder systems and automatic refill services can be very helpful. Confusion can be problematic in those with cognitive deficits or low health literacy. The lack of generic respiratory medicines, need for costly delivery devices, and limited insurance can all make respiratory medicines expensive. But in one study of patients with COPD, only 5% of respondents said lack of money and confusion about instructions were the reasons for their non-adherence to therapy. Most non-adherence is actually intentional non-adherence. That is, patients are knowingly departing from prescriber instructions. In the studies that looked specifically at non-adherence in COPD and asthma, most common reasons patients gave for non-adherence were the result of deliberate decisions. What are patients' reasons for intentional non-adherence? The reasons fell into two main categories: perceptions of their medicines or perceptions of their asthma or COPD. Perceptions of their medicines fell into three main categories. The first category was the perceived lack of benefit to taking the medicine. Some patients had a low confidence in the benefits of medicine in general. Others reported being skeptical of prescription drugs, but perceived non-prescription or complementary and alternative medicines as being safer or more natural. Others perceived their specific medicines to be ineffective. That is, they didn't see a direct benefit when taking the medicine. Patients valued the medicines helped them complete their daily or desired activities. So generally, quick relief medicines, having immediate perceptible effect, were more likely to be perceived as more beneficial than controllers which do not. Sometimes patients reported that therapy appeared too excessive. If they thought they were taking too much medicine or too many doses, they might discontinue prior drugs when others are added or not start the new medicines that were prescribed. Another reported concern was the medication, if taken regularly, would lose its benefit over time. These patients were concerned regarding the development of tolerance and therefore would save medicine for when they really needed it.